week. I'm on Lagacé, Dowson, and this webinar is entitled, What are the Real Solutions to Canada's Toxic Drug Crisis? I'm speaking to you from Tiohtià:ke, or Montreal, on the unceded territory of the Haudenosaunee Confederacy and the Kanien'kehá:ka, or Mohawk people, whom we recognize and thank. And I also wanted to issue a special thanks and recognition to Murray Sinclair, who died today at the age of 73, an Anishinaabe leader and the first Indigenous judge in Manitoba, the second Indigenous judge in Canada, and chair of the Truth and Reconciliation Commission. He died in Winnipeg today, a member of the Fish Clan and an Ojibwe speaker. And I was very touched by a quote of his that I saw in one of the tribute pieces today. He said, "At the basis of most Indigenous teachings about the path of life is love." I live in Montreal, as I mentioned. Last year in Montreal, there were 1,255 overdoses. 175 of them were fatal, and one of them occurred just across the street from where I live in downtown Montreal. For many of us, this issue is very close to us. And I wanted to thank the members of the board of the Canadian Health Coalition, thank Tracy Glynn for stick handling the tech on tonight's event and also initiating the planning for it. And thank the panelists who you see before you, knowledgeable, caring, and geographically representative, as it turns out. DJ Larkin is a lawyer and the executive director of the Canadian Drug Policy Coalition based in Vancouver. Chris Galloway is the executive director of Alberta's Friends of Medicare. And Valeria Edelman teaches social work in Fredericton at St. Thomas University and has worked on the front line as a social worker. If you have a comment or a question throughout the panel, please hop on the Q&A function and leave us your thoughts and questions, and we'll try and bundle them together and put them to our panelists. So we're going to start with DJ Larkin of the coalition. And I sort of tried to set the tone by asking our panelists, what is the most important thing for people to know about the opioid crisis? And in this case, from the perspective of the Canadian Drug Coalition. DJ?
Thank you, and thanks everyone for inviting me. I'm joining you from Musqueam, Squamish, and Tsleil-Waututh territory here on the West Coast. Bonjour à tout le monde en français. I will not be talking about data and statistics. We know what they are, and we can't think in statistics because we are losing friends, and this is what we need to conceive of as a preventable, policy-driven mass death event over the last many, many years. So I'd like to go through sort of three topic areas where we see some things that are going wrong and pathways forward. So starting with where we are at now, what we are seeing in government policy making and in public policy spheres is that the development and deployment of policy and programming is being set up to fail. And I truly mean that both in the design of what we are doing and in how we are engaging with the public. So there's two elements to public policy making. One is, what is the content of the policy? How are you resourcing it? And how are you rolling it out? Does it fit the need? And then the second piece is, are policymakers dealing with the academic literature around how to build understanding and support for policy? And what we're finding is that neither of those are happening. And in that gap is where misinformation is coming in, where people don't understand what's happening and they want to find something to blame. And things like harm reduction services and people who use drugs are now the target of that. So as one example, if we look at decriminalization policy, when you take a policy that takes away something, you take away a criminal sanction, the public sentiment around that will tend to be, I don't understand it because I'm not sure what it does, and you didn't replace it with something else. There was no education to help people understand what it did, no community engagement to help people feel like they were implicated and engaged in decriminalization policy, and no transparency around the intersections between what people were seeing in public and dramatic increases in homelessness. For example, in Vancouver alone, in Metro Vancouver, homelessness increased 32% since 2020. And that happened at the same time as decriminalization policy was rolled out as a pilot project. But when people came out from the pandemic and came out from their homes and saw more people in the street, they wanted something to blame. And government didn't engage with the fact that we are seeing an increased number of people who are living in our streets. A second example would be what we call prescribed alternatives or safe supply or compassion clubs. So again, this brings us up to the structural drivers. Everything in substance use care, everything in drug policy has to come from an exemption from the Controlled Drugs and Substances Act. So everything gets treated as an exception. We saw the federal government fail to support compassion clubs at the community level model, despite them being supported by researchers. Their year one data shows dramatically better health outcomes. No compassion club members died from the Drug User Liberation Front Compassion Club. Increased safety within the community members who are part of the compassion club, and more generally, more stability within people's lives. But again, with programs like that, because we start with a criminal legal sanction framework over top of it, it's really, really hard for communities to take care of each other. With prescribed alternatives, we saw program design that was not scalable and not adequate, both in terms of its reach, the modality of access, and the types of substances available, which means that people aren't necessarily getting what they need to make them safe, to help themselves be safe, and to help find trajectories of care. And with that comes backlash that seems to focus on the notion that these programs can't work, not that these programs have not been structured in a way to help them work as best they can. And again, coming up to that structural level, we see that we look at the criminal legal structure and the concept of diversion being posited as the biggest public health risk around something like compassion clubs or prescribed alternatives. Well, I'm here to tell you, diversion has always happened. Who here has had their grandmother hand them something and go, I got this from the dentist, but I didn't use them all. You're having a bad headache today. Why don't you take something? Secondly, the unregulated nature of the drug supply is causing immense damage and harm. It is not just our friends who are passing away. It is anoxic brain injuries that are occurring and other very serious health complications that are occurring as a result of the unregulated drug supply. So when we talk about diversion, we should actually be contextualizing that in an analysis that says, well, it's the unregulated supply that is the biggest danger. So we actually need to focus on finding alternatives to that as fast as possible. And moving on to healthcare, and I promise I'll keep to 10 minutes. When we look at healthcare around substance use, we cannot continue to depoliticize and decontextualize both substance use and the way in which we approach it. Right now, we are allowing policymakers to approach this crisis as if it can be solved through individual treatment. Individual treatment does not end a policy-driven crisis. But here what we see is really effective public communications, because we know from the literature that people are more able to understand policy initiatives where they are designed to be individualized and where they are designed to control a person's body. I can change that one person's behavior, as opposed to we need to change this structure. And so we've depoliticized it. We've taken it out of the context of the criminal law. We've taken it out of the context of the social context of homelessness, other social determinants of health. And that has led us down a road where we're trying to fund just these individual treatment modalities. In BC alone, the coroner's death review panel experts posit that there's about 250,000 people who access the unregulated drug supply every year. Only about 100 of those people might qualify for a substance use disorder. That is enough to tell us that treatment will not get us out of this, because all 250,000 of those people are at risk because the supply is unregulated. And then from there, we see how substance use care is treated as optional, because if the first step is someone should not be using drugs because we conceive of them as illegal or we have a moral or value judgment around them, then care for them becomes either optional, or what we have seen is it is largely done through private for-profit services. There's very little oversight and very little monitoring of whether or not they're actually effective or safe. And all of that is driven by narratives around the alternative is incarceration, and people are doing something that we consider to be illegal, and so this is an acceptable outcome. But we believe, I think, in universal health care. And so we need to reconceptualize that. Universal health care is for everyone, and these modalities of care around substance use need to be incorporated properly into universal healthcare systems. And we know that it's also hurting workers, because there are so many people having urgent medical emergencies related to the unregulated supply. Emergency workers can't keep up. Supervised consumption services are overrun. Frontline workers are overrun. Our emergency rooms are full, and more people have preventable traumatic brain injuries. Why would we not adopt a system that actually prevents harm? And so that brings me to the last few lines and the kicker of all of this. If we want to look at solutions, we have waited too long. Canada used to be seen as a leader, but in fact, we have waited too long, and the steps we took were far too small. And that is when we do that, what we see is backlash tends to occur because people don't see the results that they want. And so in 4 years from now, we need to see transformational change. The United Nations High Commissioner on Human Rights is calling for responsible regulation. All of the data suggests that moving towards public health regulatory models that properly control the drug supply and actually properly control access to it, because that is not happening now. Prohibition doesn't actually control access. It means that people are purchasing drugs. No one's checking ID. No one's checking contents. No one is actually monitoring and controlling it properly. And we need to move away from this system. All of the data seems to indicate that this is not working, and it has not for over a century. So over the next 4 years, if we want healthcare workers to have more resources, we need to silence all of those sirens. And we can do that by displacing the unregulated supply. And then we can reinvest those resources into the supports that people need, whether it's treatment, housing, or other services. I'll stop there. I hope that is broadly helpful, but overarchingly, from our perspective, the Controlled Drugs and Substances Act needs to be completely rewritten through a public health lens.
Anne, you're muted, Anne.
Sorry, pandemic mistake. Sorry about that. Thank you, DJ Larkin, lawyer and executive director of the Canadian Drug Policy Coalition based in Vancouver. And if I can just sort of take what you said and resume it, synthesize it, I think the kernel is addiction care is healthcare, fundamentally. And that's a good way to segue to our next speaker, Chris Galloway with the Friends of Medicare in Alberta, which you could argue is one of the frontline positions to be in on this policy debate, including, for example, today, a piece that appeared in the Globe and Mail written by a guy who teaches at the University of Calgary, who is in favor of involuntary treatment, which is kind of anathema to what we were just describing. So I'll just hand it over to you, Chris Galloway, ED of Alberta's Friends of Medicare, friends and allies of us at the Canadian Health Coalition. That's bad grammar. Take it away, Chris.
Awesome. Thank you, Anne. And thanks for having me. I'm joining you tonight from Treaty 6 territory here in Edmonton. And I just want to use my time to kind of tell you the story of what's happening in Alberta, but also why, because I think it's important to how we address what's going on. But just before I start, in case you haven't heard of Friends of Medicare, we're a nonpartisan advocacy group here in Alberta. We've been around for over 45 years fighting for public health care along with the Canadian Health Coalition. And Anne took the words out of my mouth. I want to be clear that we believe addictions care is health care, and that mental health is health care, and that harm reduction is health care. And these services should be run and delivered as part of our public health care system. So that's why at Friends of Medicare, we have 4 kind of priority areas we campaign on, and the drug poisoning crisis has been one of those areas for many years. So it's really important to us. But unlike what we were just hearing, we are not using a public health approach to this crisis here in Alberta. And that's what we think needs to happen. So instead, what we're seeing from our government is a very ideological approach, but I also want to make it clear that it's a political strategy that they're putting into place, right? So they call this the Alberta recovery model. It's very well marketed, and it's a model that's pro-criminalization, it's anti-harm reduction. They constantly actually create this false dichotomy between harm reduction and treatment, like they're opposing forces as they close more and more harm reduction services in our province. And they're very focused on abstinence-only individual recovery type models. Forced treatment is what they've promised to bring. And it's all anti-evidence. There's nothing to justify what they're doing when they're selling this model to Albertans and elsewhere. But I just want to be clear, it's not incompetence. It's not that they don't know what they're doing. It's a political strategy. They're trying to rile people up. They want to talk about this as a crime and safety issue. They want to create fear and division to avoid actually tackling what's going on, because they think it'll get them votes, that they'll win seats by doing that they can fundraise off of it, and they do. It's a political strategy to maintain power and to divide people. avoiding the fact that people are dying in record numbers as they're doing this. So that's what's really happening. But it's also a strategy of privatization, and it's about profits. That's what's happening here in Alberta. If you're not following what's happening to healthcare in Alberta, our government's actually doing a massive overhaul of public healthcare. They're blowing up Alberta Health Services, which is our provincial agency that runs healthcare for the majority of healthcare in the province. They're creating these 4 sectors that are going to run different types and pieces of healthcare. And Recovery Alberta is their flagship sector agency that took over on September 1st mental health and addiction services away from Alberta Health Services here in Alberta. It was a rocky, delayed start, and it's not done, but overall, they're now running mental health and addictions in Alberta. And if we watch the rollout of Recovery Alberta and this recovery model, we can see that it's really about profits and actually creating a market for those privatized services. That's what they're building. And which is why at every turn, they're signing contract after contract with private providers and taking those services out of the public system. So in Alberta now, I'll miss many of them, I'm sure, but we have multi-million-dollar contracts for private recovery centers, for private curriculum development, for a private training institute, for private treatment services in our corrections facilities. We have this My Recovery app, which is an app they push people to use, which is actually a private app that owns and controls the data that's collected, not the government or the health system or the patient, but this private corporation owns our information. It's clear over and over that that's what they're doing, is creating this for-profit healthcare model in addictions care. And it's so clear, an example that really highlights what they're doing. After getting elected, the UCP government closed a treatment facility, a public center in Gunn, Alberta, the community of Gunn, laid off all the workers, all the unionized workers. And then just this summer, they turned it over to a private recovery center to run that facility. They had this big press conference, they cut a ribbon and announced how they were creating more spaces for addictions treatment in Alberta, but they weren't. They just flipped them from a public center to a private center. And what's common with any privatization strategy, which the Canadian Health Coalition and others will know, is that it's about busting the unions and it's about lowering the regulations of what care is actually being provided. So you may not know, or you may not realize that here in Alberta, addictions counselors are an unregulated profession. Anyone can be an addictions counselor here in Alberta. And we were set to finally fix that. There was regulations coming to actually have a college and regulate counselors here in Alberta, but the UCP put a stop to that after they got elected. We're no longer moving forward with that. So this is unregulated care that's being offered. And they went even further and they created this new idea of a recovery coach, where after a few hours of training, you can work as part of this recovery model, the Alberta recovery model. So what we're left with in terms of what's happening here in Alberta is this classic war on drugs approach, this criminalized approach. It's highly unregulated, and they're creating a patchwork system of private providers. And like I said, none of this is based on evidence. The government regularly claims this is a big success, that they're a leader in the world, but they refuse to release data, timely data or any data at all often, on what's really happening. They refuse calls from ourselves and many other groups to release information on recovery spaces and other evidence that would support their claims. They refuse to put it through FOIP. They're being very secretive about what's really happening. And in fact, they're being so secretive and so driven by message over results that as part of the restructuring, they also announced a new Crown corporation called CORE that's going to be this propaganda machine that's mandated to sell the Alberta recovery model as a success to Albertans and outside to other jurisdictions. And they set it up purposely as a Crown corporation so it wouldn't be covered by public scrutiny or FOIP or things that could actually check against what they're going to do and say. We had a similar war room you may have heard of for the oil and gas industry under the last term of the government. So they're actually creating up a whole machine to try to sell this model. So that's what I'll close with. For those, I know some are from Alberta in the attendees, but from across the country, a lot of premiers like Scott Moe in Saskatchewan and others have stood with our government to say they're going to work together to expand this recovery model across the country. Their federal allies are saying the same thing. It's the same political strategy. And we should all be quite concerned about that because it's not a public health approach. It's not about keeping people alive, and record numbers of people are dying. And that is the solution. We should be doing everything we can to keep people alive. So I'll leave it at that. And I'll throw a link in the chat. If you're in Alberta, we have a ongoing action around supporting harm reduction services that I'll share in the chat. But thank you.
Thanks very much, Chris Galloway, Executive Director of Alberta's Friends of Medicare. And just before we go any further, somebody asked a question, which I think we should probably answer. What is a compassion club? And I wonder if DJ and you, Chris and Valeria, want to take a run at that, because somebody just asked that question in the Q&A. Sorry. So DJ?
Certainly, I'll answer with regards to specifically what I was talking about. Compassion clubs are a thing that exist in a number of ways and sectors. Specifically, what I was referring to was a compassion club where you have members who are part of a club. There are people who use drugs and have for a long time and are at risk of fatal overdose and non-fatal overdose from the unregulated market. They created a club where they bulk purchased drugs, tested them, labeled them, tested them through multiple drug checking systems, labeled them with health warnings, labeled the contents, and they were sold at cost through that pooling together of member money so that they knew exactly what they were getting, how much, they knew what was in it, they could rely on the relative safety of it. And because it was done through a compassion club model, it was for members only. And so there was high-level assurances that the people who were members of the club were also the people who were using those substances. And in the first year of its operation, the data suggests that it was very, very successful. No one died. Overdoses were way down. Hospital visits were down. Police interactions were down. Housing stability was up. All of those determinants were good.
Okay. Did you want to add anything, Chris or Valeria, on that? Okay. I hope that answers the question that one of our attendees, David Alper, asked in the Q&A. I would invite those people who are listening and who have queries for our panelists to jump into the Q&A and throw your questions in there, and also your comments so we can put them to the panelists. Last but not least is Valeria Edelman, who teaches social work in Fredericton at St. Thomas University. She's worked in mental health and addictions in both BC and now in New Brunswick. And I cannot remember the name of the territory, Valeria, so help me out on that one.
Lagacé.
Okay, gotcha. Okay, over to you, Valeria.
Thanks. So yeah, I've got PowerPoints to keep me on track. And thank you, DJ, for talking about the problem of not having like a regulated supply. And I appreciate hearing how the rise of privatization of healthcare in Alberta is affecting people there. New Brunswick has often looked at Alberta as a role model. So what Alberta does, sometimes we'll see down the line here. Okay. So thank you for having me speak today. It's a privilege to have my voice heard by like so many people here tonight. So I'm gonna try to Tracy to go to the next slide. Do I have control over it? No. I'll do it. Okay. So next slide. There we go. So this is an overview of my short presentation. I'll share key concepts that inform my position on the toxic drug crisis. What we know is not working and the barriers that we can overcome to affect change. Next. So though as humans, we can all relate to opiate use, we draw lines in the sand and we uphold notions of us and them and a hierarchical power dynamics, and that has significant consequences. Next. Thanks, Tracy. So I use Dr. Gabor Mate's definition of addiction. So note his definition includes any substance use, any behavior that can provide temporary pleasure or relief. Who doesn't want temporary relief? Right? It's a very human thing to want. Dr. Mate has also explained how childhood trauma reduces pathways for endorphins. Opiates serve to release endorphins. Endorphins alleviate pain and deliver a sense of well-being and inner peace. Who doesn't want to experience relief from physical, emotional, and spiritual pain? Who doesn't want a sense of well-being? Opiate use and addictions are understandable human experiences. Next slide. Yeah. So while we can all relate to wanting to feel better, there are lines drawn in the sand about socially acceptable ways to do it. No one is watching me eat a bag of chips on a Friday night, despite my high risk of diabetes. True story, right? There's designated cigarette smoking sections on campus. No one is trying to stop the nurse from drinking a bottle of wine after her shift. The stigma is targeted on people who use illegal drugs. The belief that opiate use is somehow so much different from human experience, it's such a different human experience. It helps maintain these archaic laws which push people into the margins, into isolated conditions where secrecy feels safer than stigma, even when there's a risk of overdose. Next slide, please. Some people struggle with addiction and the negative consequences from drug use. But for some people, the negative consequences come from stigma, judgment, and criminalization. Next slide. We live in a culture that disproportionately values people based on their participation in the workforce. There's a growing wealth gap, food apartheid, lack of affordable housing, colonialism, and social stratification. While preventable deaths from a toxic drug supply affects people from all walks of life, in Canada, it disproportionately affects Indigenous people and people living in poverty. So an effective response to the opiate crisis would respond to other issues too, these other social issues too. Next slide. The last foundational principle in my position comes from the work of Vicki Reynolds. Through resisting individualizing the problem and instead addressing structural violence, we can shift from shaming, blaming, or even saving relationships to ones that center respect and dignity, ones that can produce sustainable and effective approaches to problems when we work together. Next slide. We know that marginalization and exclusion does not solve the toxic drug crisis. We know this. Next slide. In Fredericton, our last government, who fortunately, in my opinion, lost the recent election, they started building a new jail to clean up the streets, quote unquote. They also had a plan to introduce mandatory treatment legislation inspired by our friends in Alberta, despite public outcry about its proven ineffectiveness and likely harm. Next slide, please. Generalizing that all people who use drugs have an illness and need treatment can produce similar results as criminalization. Drawing lines on what drugs are unacceptable to use reproduces stigma and discrimination. While some people want to have treatment, want to have use a recovery model, there are people who do not identify with having an addiction and seeking healthcare, and they're criminalized for using drugs. And that's a population too that we need to consider. Next slide. We can't work in solidarity with people who use drugs by only focusing on drug policies. We need to address power dynamics based on socioeconomic status. Okay, next slide. So this is a news clipping about a shelter, not just a shelter, it was a hub, had many services, and it was at risk of getting shut down. It's a happy ending. The service providers had advocated at City Hall, and the center remains open. But this story demonstrates assumptions about people who use illicit drugs, how they can be framed as people to fear. If you look at the last couple of lines in that story. And this article also shows how drugs are framed as the cause of crime, rather than poverty as the real culprit. This article also shows the counselor representing particular residents in the neighborhood at the expense of other people who also live in the neighborhood, and the consensus through silence that this is okay. So there is some potential for residents in the neighborhood to get to know each other, become less scared. Though I have some ideas about how to approach problems in this neighborhood, I'm an outsider. So I would collaborate with people who visit the center and live in the neighborhood before making claims that I have the answers. Next slide, please. Insider knowledge from living in poverty, injecting drugs, being diagnosed with a mental illness has proven to be an asset for many organizations. Those working with highly stigmatized populations, especially those who do not have lived experience to deeply understand the realities in those communities, where they work, tend to value people with lived experience as perspectives. Next slide. For real solutions to the toxic opiate crisis, there must be solidarity work with people who are affected by the issue. Guides such as this one, which was created by the Canadian Association of People Who Use Drugs, can help bring together academic-based knowledge, professional-based knowledge, and lived experience-based knowledge. But what I'm finding is organizations, they struggle with resisting deeply entrenched beliefs about highly stigmatized groups. Next slide. The entrenched power imbalances based on privilege and oppression from broader social conditions are replicated within organizations, marginalizing and limiting people with lived experiences contributions. Next slide. Even when organizations have intentions to meaningfully include people with lived experience, when it comes down to it, people with lived experience can feel railroaded, tokenized, or positioned in organizations like they're doing them a favor by including them. So there are significant power imbalances within organizations that go unaddressed. Next slide. So we need to address these power dynamics. We need to examine the underlying beliefs that perpetuate stigma within organizations that are trying to find real solutions. We need to examine conditions that get in the way, like possibly neoliberal priorities of efficiency over inclusive decision-making. So there's a saying, the fish is the last to discover water. What is our water? That's all around us, that's getting in the way of like real collaboration. Next slide. Got a list of references, if you want to screenshot or call me after. And then next slide. So thank you. Please reach out to me if you share similar interests and you want to work together, or if you have any questions for me.
Thanks, Valeria. And somebody put a question in the Q&A. So that was Valeria Edelman, who teaches social work in Fredericton at St. Thomas University and worked as a frontline social worker in mental health and addictions, both in BC and in New Brunswick. So Valeria, somebody asked the question, how does a citizen get involved in promoting harm reduction and policy change in their community? So it's a perfect question for all of the panelists. Somebody's wondering, okay. Yeah. Now what do we do? So do you want to take that, Valeria, and then the other panelists can jump in?
So I have a couple thoughts. Okay, one is like generally, like you don't have to wait for people to be drug-free or in recovery to include them in community and community organizing. So if someone wants to get involved, to get in policy or services, can you repeat it?
Well, it doesn't, somebody wants to know, how does a citizen get involved in promoting harm reduction and policy?
Promoting.
Yeah.
Okay. Yes, that's a really good question. And I appreciate that because we can all do that part of promoting harm reduction, right? And so part of that harm reduction could include, we call it like being a YIMBY instead of a NIMBY, like a yes in my backyard. So, developing relationships and friendships or neighborly type of friendships with people who are using drugs, destigmatize drug use in conversations with people. Attend City Hall. I always find like changes on the municipal level are often a lot easier to manifest than provincially. So attending City Hall meetings. Yeah, those are some ideas.
Okay, Chris, do you want to jump in, respond to this query?
Sure. If you're in Alberta, you should take our action and get our updates on what we're doing. But there's groups all over. There's
I'm going to jump in and say you should get on the Canadian Health Coalition mailing list too.
also that, yeah.
Yeah.
And there's groups across the country and locally, like Mom Stop the Harm and others who are actively doing things. And there's ways to get involved. There's International Overdose Awareness Day and those kind of advocacy and community events. And most communities have different groups. Like in Edmonton, we have 4B Harm Reduction and others who are actually on the ground supporting people, and they're always needing support or donations or food or whatever they're dealing with. Winter's coming. There's going to be call outs for all sorts of things to help folks because we've had our folks living on the street triple here in Edmonton in the last couple of years. It's really bad, so there's a lot of need. You can also stay informed with like Drug Data Decoded and other or folks who are doing research on this. But to go to the YIMBY comment that was just made, in every municipality in Alberta, pretty much where there's any sort of harm reduction or shelter services, we're seeing these fights at the municipal level, trying to close them or prevent them from opening. And actually showing up and participating in those processes is so important because it's very easy for the folks who want to try to keep it out of their neighborhood to win. And they have been winning if folks don't speak up and support. And then just the last thing I would say is, you could get naloxone training, you can carry it, you can bring it to your workplaces, you can bring it to your community leagues to have naloxone trainings as a community and talk about it. There's all that kind of stuff that happens at the grassroots level that you could request groups to come and do that. So there's some thought.
Naloxone being the antidote, the overdose antidote. That's not too complicated to administer. My daughter, who's a nurse, showed me how to do it, and you can get the kits at the pharmacies here in Montreal. Did you want to add anything, DJ Larkin?
I'll just be really brief. That idea of getting naloxone training and bringing naloxone training into spaces where people presume themselves to not need it, I think is really important. I went and worked at a private law firm for a few years and made like the partners at the law firm get it because they don't think it affects them, and it does. And there were people who came up after and said, actually, I'm really glad there's someone I'm worried about, or it never really occurred to me that this is something we should all know. And it really breaks down that notion of who we are all in this together, or us versus them. The only other thing I would say really is if there's a local harm reduction provider, get in touch with them. Ask them, are there community engagement things that you do or where there would be benefit to having someone help out? Is there something coming up where I can participate? Because these are really, really busy under-resourced services. And when you are doing engagement, it's just really important to remember myth busting doesn't always work. Sometimes it just reinforces the myth. So start with building shared values. Do we all agree that we want our communities to be safer? Do we all agree that we want to prevent harm? That's great. Here's some ways to do that and build off of those shared values rather than sort of doing myth busting or that kind of like antagonistic dialogue with people can be really, really effective.
So where I live, there's a kind of a pitched battle going on between the sort of pro harm reduction YIMBY people and the people who are really upset by the presence of unhoused people, some of whom are addicts, some of whom aren't. There's sometimes rowdy and unpredictable behavior that they may or may not display. There's a feeling that the city is out of control, it's too messy, etc. And then there's, you know, an incident with a machete in downtown Toronto. Like there are people who are really upset by the perception that the people who land on the sidewalks are a threat. And I'm of the opinion that they're not. And I've had this discussion that they're a much bigger threat to themselves by far than to any of us passing by. And that we need to show a certain degree of compassion. If we're uncomfortable, then maybe avoid. But I mean, they're not a big problem. But this is like a very big blockage, I think, in terms of dealing with some of the debate. I wonder if you would like to jump in and tackle that kind of fear factor that is being played up by people like Danielle Smith and others. Maybe Chris, do you want to take a run at that?
DJ had unmuted, so. Okay. Yeah, like that's part of the politics of it. You know, they create that fear, they sensationalize those stories. They literally send emails saying the NDP wants to bring drugs to your schools, you know, like it's sensationalized crime. And you know, if we actually wanted to do something about it, we would house people, and we could house people. But it's also not just a problem in, you know, downtown Edmonton where there's a higher number of folks living on the street. People are dying all over Alberta, in communities and neighborhoods all over Alberta, in record numbers every single day. And the government wants to claim it's an addiction problem and a houseless problem, but it's not. It's everyone everywhere. So I think there's also battling that stigma that there's people dying everywhere. You can look at the maps they create of EMS and fire calls in Edmonton. It's every neighborhood. It's everywhere, right? So we shouldn't stigmatize who's being impacted by this, but also like housing is healthcare. Just house people would be a whole second webinar and rant I could go into, but I'll stop.
Oh, Larry, did you want to add anything?
No, I ditto. Like, yeah, housing and poverty. I think people can frame like the reason that someone is homeless is because they use drugs, right? So we kind of hear that, and that kind of has to kind of get flipped around. That we have homelessness, and the homelessness is a result of unaffordability, lack of social housing, and lack of affordable housing. Not because of drug use.
I wanted to mention just that you started with a quote from Gabor Mate, his definition of addiction, and he's been very upfront about his own history and his own addiction. And he talks about how what you so eloquently described, Valeria, like the desire to relieve stress and emotional and psychological pain through the consumption of various substances, including opiates, but also other things. Because Gabor Mate talks about being addicted to shopping and buying CDs, endlessly shopping, spending way too much money, ruining his bank account, and never really being able to alleviate the desire he had for the relief that music provided to him. So, you know, the idea of addiction is a very broad concept. And I really appreciated you adding that into the presentation today. So I'm just going to go back to the Q&A here. Go ahead.
Can I link that to what DJ was saying before about the unregulated supply, right? So, because it's a toxic supply. So we all have this need. We're searching for ways to feel better. We can relate to that. And now we have a problem that one way of feeling better, because it's unregulated, then it's a lot less safe. And that's one of the reasons why it's so unsafe, is because people don't know what's in it, and it's not regulated. I just wanted to add that.
Right. Like and what Chris was talking about, how the overdoses and the fatalities occur right across the demographics of Edmonton, right across the demographics of the country. When I was living in Westmount, fancy Westmount in Montreal, one of my neighbor's daughters died of an overdose. She bought some drugs at a party. They were contaminated with fentanyl and some other stuff. And she came home, laid down with a headache, and died. And this is very Tony, the family, both parents were lawyers. No offense, DJ. Anyway, the point being that these were affluent, well-educated people, and their daughter died nonetheless. So I think that was a very good point to make. Okay, so I'm going to go back to the Q&A. Somebody who has a comment from Alberta, I can just bring it up for for you, Chris. This person says, anonymous attendee says, my sister had a chronic liver disease and was dead within a year of moving to Alberta. So this is about the collateral damage of the drug policies of the province. While their drug policy wasn't directly responsible, it endangered her every time she entered the hospital. Hospitals kept trying to give her ibuprofen because of their anti-opiate policies. She eventually did die. They failed to admit her when her organs began to fail, dismissing it as food poisoning. So this policy is irrational and inhumane on so many levels, including towards people who are just ill. They're not addicted. Here's a question for all three panelists. Do you think if the federal government changes that they will implement things federally like they have in Alberta? So a prohibition-like policy if the Pierre Poilievre Conservatives get elected. DJ?
Without wanting to take a partisan position specifically, what I can say is we see a move towards exactly what Chris outlined. It is going back very much to the war on drugs. And I'll just say this is nothing new. 1907, prohibition really took hold in this country and in fact internationally. And it started with a race riot about 3 blocks from where I live. And it was about opium dens. And then just built and built and built from there. And we're talking about Just Say No to Drugs in the 80s and, you know, DARE in the 80s and 90s. We're coming back to that system again. And the reason is because while those policy solutions do not work, policies become very popular when you first make people feel afraid, and second, give them a solution that seems simple. And so we will see these continuing sort of go back to things that just haven't even worked for 125 years. And where we see a lack of support for universal healthcare, this is the inroad into breaking the universal healthcare system. Because we have this criminal legal model over it, there is so much stigma around drug use. This is the place where people won't pay attention if policymakers try to privatize our universal healthcare system. But this is an inroad. This is a way to get rid of unionized healthcare workers, get rid of publicly available universal healthcare, and then it starts to roll from there. So I think we do need to be very cautious about what is coming because the policies don't work and the impact to our universal healthcare and our promise and our value of that is very much at stake.
Chris and Valeria, do you want to jump in?
What DJ said.
You've just been waiting for an opportunity to say that. Valeria?
I'll just add, yeah, it's not just about drug policies, right? Like, even like the race riots in, like over 100 years ago, it was also about like union busting. It was also about capitalism. It was also about, these, to kind of echo these like simple solutions of criminalization and jails, and policing and, are proposed to very complex problems and social issues that affect so many people beyond people who use drugs.
Back to the Q&A. Somebody who wants to know, will there be a way to get a recording of this webinar? The information is amazing. That's from Donna Colpitz. So kudos to the panelists. And yes, we're going to put this up on our YouTube channel, which is where we put all of our webinars. Many excellent webinars can be found on that channel, including one that's coming up on the 21st. Tracy, do you want to jump in and just mention what the next webinar is?
Yes, it's with Dr. Nisha Kansal, and she's with the Healthcare for All Coalition. She is a doctor in Toronto and has some experience with providing healthcare to migrants and the uninsured. And she will be talking to doctors and healthcare providers, but also the public who want to find out more about how healthcare providers, how they can provide healthcare to people who currently don't have access to Medicare.
And that's on the 21st. That would be
Yes.
another rendezvous for people who are interested in in that aspect of healthcare. So that is Donna Colpitz. Now we have a comment from Jeanette Pongratz Doyle, who says Island Health had a vending machine outside the hospital in Nanaimo. DJ's nodding their head. Free drugs and pipes and anything they needed, another machine with free drugs. The addicts took the pipes and sold them to get money until it was exposed to the public. A failure by government, a total failure to help anyone. Even the addicts said how stupid the government was as the overdosed addicts left the hospital and gave them free controlled drugs on the way out the door. So interesting policy failure there, DJ. I wonder, can you give us some context on that?
There's been quite a bit of confusion around different things that have been rolled out in BC. It's true that there are harm reduction dispensing machines and that there's been some backlash against those. Again, some of the backlash that we saw was really around this narrative of the fact of there being dispensing machines that dispense things like clean, healthcare supplies were somehow going to encourage people to relapse. I'm not aware of any data that supports that, but certainly there's significant data that supports the need for clean harm reduction supplies in terms of stopping transmission of viral and bacterial infections and stopping other like health harms from reusing supplies like syringes, like pipes and things like that. As it relates to very small pilot models of using a biomedical, like there was a very small model of a dispensing machine for prescription alternatives. It was a very small pilot project. The one I'm familiar with more is in Vancouver, and that was really using, people's sort of like fingerprint data to access those machines, and they tried to make it quite controlled. So these aren't things that are happening at a dramatic rate, but what did happen is people became very attuned to it because we were in the middle of sort of a general moral panic around the notion of harm reduction. So we started to So we started to see quite a bit of concern around anything related to harm reduction and the provision of it. That said, I do think there's a need when we're developing policy and programming to be thinking about how do we bring people into community, how do we ensure that people are connected to care, and how do we provide for those spaces where people have trajectories towards wellness, whether that's abstinence or other modalities like methadone, like OAT, things like that. So when you're talking about dispensing machines for harm reduction supplies, you're not getting that personalized interaction, and that would certainly be a limitation of projects like that. But I think what we see in BC right now is that we're seeing a moral panic growing around a number of issues, and it's all pointing towards very specific harm reduction programs or drug policy programs in order, once again, like we said, to come back to that notion of let's blame this so that we can go back to ignoring the fact that we have a housing crisis, that our healthcare system is overburdened, and go back to those sort of criminological approaches that have not worked.
Was this also raised as in the context of the recent provincial election?
Oh, drug policy was all over the recent provincial elections, certainly. And what we saw is across the spectrum, with the exception of one of the smaller parties, a real move towards this notion of public safety, which once again sort of redirected attention away from the public health crisis and towards notions of public safety, which once again conflates the fact of being homeless or being in a public space with being inherently a risk to the public. The data does not support that. In fact, people are much more likely to be assaulted or to be harmed than folks are to harm others. But we do tend to really rely on those very few exceptional circumstances and try to generalize from them. Where someone does do an act of violence, we tend to over focus on that and try to generalize that notion to assume that everyone will behave similarly. So this election was involuntary treatment, canceling decriminalization, some politicians positing that we should cancel supervised consumption services. But then on the other hand, we had a political party running based on actual policy and programmatic reform that was publicly endorsed by the coroner, the former coroner of BC, because it was actually evidence-based and could have made a difference at a population level.
Okay, so back to the Q&A. So a comment from Ruth Wolf, who says they were involved in Edmonton's first needle exchange program in the 90s. Worked in Vancouver as well in the 2000s, and asking, can panelists comment on anywhere where effective policy has been implemented? If so, what policies were effective and by what measure? What was the political climate in which effective policies have been implemented? And how was backlash navigated? So this is a person who's a bit of a veteran in the field, feeling a bit discouraged. I wondered if anybody wanted to jump in. Chris, do you want to dive in here?
Sure. I think a couple of things, and it is sometimes hard to be hopeful when talking about this crisis. And I talk to many people impacted by it, and it's upsetting, right? That people are dying. We have seen, and politics plays a role in this. Like in Alberta, when the NDP got elected, I was actually quite surprised, having moved here from Saskatchewan, that they moved quickly to implement a whole bunch of supervised consumption sites and harm reduction programs without a lot of fanfare, without endless, you know, consultations at the community level trying to. They just did it because it was a health crisis, and they saw them as health services, including opening services within one of our hospitals here in Edmonton. So sometimes we just need political folks who are just willing to act and do it rather than create these fights. So I think there's that piece to it, but I also think there is, as much as there's this torqued politics around it, there is public support too. So I used to live in Saskatoon many years ago. I was involved in an organization that did harm reduction there, and now Prairie Harm Reduction's there that operates. They're a great group, but the government refuses to fund them in every budget cycle to actually provide the services. And the community for years has stepped up to donate and fundraise and fund that supervised consumption site so that it can operate. I'm wearing one of their shirts right now because that's part of how they fundraise. And people lined up to like go to the movie theater and buy popcorn on the day that all the money was going to them. Those kind of actions where we really can build a community response and do it ourselves if we have to. So I think there's that piece, but also we just need some, political boldness at times too. And, it's on all of us to push for that, including, the Health Coalition and Friends Medicare and others. But yeah, I do think there is, a compassionate world of support for this stuff if we can organize ourselves as well.
Valeria, did you want to say anything?
Like I've seen partially good. I think there are policies that we can build on, right? So I think particularly in BC, I think BC are the forerunners. I don't know. Like when I was in BC, I was in a bit of a bubble. I didn't know what the rest of Canada really was, and then when I came to New Brunswick, I was like, oh, okay. So BC is special, and so I think that they have. I can't speak to any specific policy right now, but like the supervised consumption sites, those compassion clubs. And they did that with alcohol, similar with alcohol too, where people had to do their own like brew, and they had like a drinkers club. So they had a lot of like innovative ways that kind of came from the community up, because each communities are different. So you have these overarching like policies, like we need to have like kind of raw laws that can regulate supply. And there's also these smaller like policies, on the municipal level and community levels.
I just want to jump back in one last time into the Q&A because we're coming up, banging up against the clock, as we used to say in the radio business. A comment from Ron Reinhold, who says, in Calgary, our MLA had a meeting at the community center and trained us how to administer naloxone. 2 months later, my employee saved someone at a homeless center in Calgary. So exactly what was mentioned earlier. So that is at least one small step that people can take, is just to learn how to manage naloxone. And it's not super complicated. Like I figured it out, so it can't be that difficult, right? And then Ron Reinhold says, in Alberta, unfortunately, we need to get involved in the political process at this point. So that's really, I think, probably a good way to close off the proceedings. And there's a couple of other people who put comments in the Q&A, and I would really strongly suggest you contact DJ Larkin at the Canadian Drug Policy Coalition, or Chris at the Friends of Medicare, or Valeria at St. Thomas University, because some of your questions are a little bit specific, and I think our panelists can answer them, and you can easily access them via their web pages, in addition to ours at the Canadian Health Coalition. So I want to close by thanking Tracy Glynn for managing all of the logistics of getting everybody up on the webinar and looking so attractive on screen. And I really wanted to thank our panelists for their incredible generosity, both in the context of this webinar, but in the work that they do. So a big thank you to DJ Larkin, lawyer and executive director of the Canadian Drug Policy Coalition, Chris Galloway, who's the executive director of Alberta's Friends of Medicare, and Valeria Edelman, who teaches in the social work department at St. Thomas University in Fredericton, where our colleague Tracy Glynn also teaches. And a big thank you to all of you for joining us tonight. And I would just invite you to go onto our YouTube channel, because we're going to put this up on the YouTube channel, and you can listen to it at your leisure and stop and start and interrupt whenever you feel a need. And we'll be bringing you more webinars as time goes on. So my name's Anne Lagacé Dowson. Je vous remercie d'avoir été avec nous. And we'll see you at the next webinar on the 21st, hosted by Tracy Glynn. Un très grand merci à vous. Everybody take care of each other. Ciao.